The first of these guidelines was the Australian Dietary Guidelines, and on your screen you can see the dietary pyramid based on the 1982 guidelines. So the dietary guidelines recommended a diet based upon carbohydrates, including cereals, fruit, vegetables, bread, pasta and rice. In the middle of the pyramid is proteins, and we're advised to ensure an adequate amount of protein, and at the top are fats. We're advised to minimise our fat intake, and in particular to avoid saturated fats, or to swap them out for monounsaturated fats or polyunsaturated fats, the sort of fats that come from seed oils. So as a country, we've been following the Australian Dietary Guidelines for 40 years. So how has that turned out for us? As a general practitioner, I've had a front row seat to the evolving disaster which has become the Australian healthcare system. We've had a tsunami of chronic complex diseases underpinned by poor metabolic health, including insulin resistance and type 2 diabetes, which has overwhelmed the capacity of our system to cope. Since I have been a doctor, there has been a fourfold increased incidence of obesity, so that we now have 32% of Australian adults and 8% of Australian children suffering from obesity. In fact, 3 out of 4 Australian men, 3 in 5 Australian women, and 1 in 4 Australian children now suffer from overweight or obesity. The incidence of type 2 diabetes has doubled in this time, and we've seen the evolution of type 2 diabetes as a diagnosis in children, something that I could not have imagined when I first graduated. We've also seen the evolution of new diseases caused by poor metabolic health and insulin resistance. Fatty liver disease or metabolic associated fatty liver disease was not taught when I was at medical school because it was only first described in the literature in 1980. This is a disease which causes inflammation, fibrosis and cirrhosis of the liver and increases the chances of developing liver cancer. It is now the 3rd most common cause of requiring a liver transplant in this country, and it affects 1 in 4 Australian adults and an increasing number of Australian children. So how was I going? This is a photograph from 10 years ago of me sitting at my desk in my general practice, and you can see that I wasn't going particularly well. I had obesity, pre-diabetes, fatty liver and sleep apnea. I'd been on a low-fat diet for 40 years, and I had struggled with my weight my entire life. I'd been on and off diets mainly consisting of eating less and exercising more, achieving weight loss only to put that weight on and some more. I'd pretty much given up hope. I decided that I was going to be obese for the rest of my life and that I would develop type 2 diabetes, and there was nothing I could do about it. It was about at this time that I came across low carbohydrate diets and was fortunate enough to travel to Sydney to attend a low carb down under conference. There I met dietitian Nicole Moore, who taught me how to live a low carbohydrate life and then a ketogenic life, and I had great success. For the first time in my life, I lost weight and sustained the weight loss. I reversed my pre-diabetes and my fatty liver and my sleep apnea. And over this time, I had a couple of light bulb moments. The first of these is that insulin resistance and type 2 diabetes is caused by carbohydrate intolerance. So it's consumption of carbohydrates which cause insulin resistance and drive up insulin, causing the hyperinsulinemia, which is associated with the beginning of type 2 diabetes. So if I was allergic to peanuts, therefore I was intolerant to peanuts, I'd be advised not to eat peanuts. If I had celiac disease and I was intolerant to gluten, I'd be advised not to eat gluten. So why is it that we advise people with type 2 diabetes that they can consume as many carbohydrates as they like? The second light bulb moment for me is that out of the 3 major or macronutrients, carbohydrates are the only non-essential one. So there are essential proteins and essential fats, but there are no such thing as essential carbohydrates because the human body has the capacity to manufacture as much glucose and as much carbohydrate as is required. About this time, I started offering low carbohydrate nutrition as a tool for some of my patients with type 2 diabetes. And this is the lovely Helen who agreed to allow me to share her story with you. So Helen presented to see us in February of this year. She had the full hand of diagnoses associated with insulin resistance, including type 2 diabetes, high blood pressure, fatty liver, and sleep apnea. She was on a range of medications, including those to treat her high blood pressure and her diabetes, but she was also on medication for her cholesterol. She came to see us and we commenced her on a very low carbohydrate ketogenic diet consisting of less than 20 grams of carbohydrates per day, an adequate or an optimal amount of protein, and fats titrated to her hunger or titrated to her satiety. Over a 3-month period, we monitored her and then repeated the blood tests which we had done at the beginning. At the beginning, Helen had a hemoglobin A1C of 10.1, which is consistent with extremely poorly controlled type 2 diabetes. 3 months later, her hemoglobin A1C was 5.2, which is consistent with non-diabetes. At the beginning, she had severely abnormal liver function consistent with her fatty liver disease. 3 months later, she had normal liver function. At the beginning, she had a fasting blood sugar of 19.2, which is extremely high. 3 months later, her fasting blood sugar was 4.4, which is very much in the normal range. At the beginning, she had a blood test consistent with kidney impairment or renal impairment. 3 months later, she had normal kidney function. At the beginning, she had a triglyceride level of 3.9, which is consistent with insulin resistance and type 2 diabetes. 3 months later, this was 1.4. So every time this happens, it feels surreal. It feels like I'm experiencing some sort of miracle. It's like something that I have never seen before. Over 40 years of treating patients with type 2 diabetes, I have seen a consistent progression of the disease with an increasing need for more and more medication and ultimately the need for insulin therapy. With time, I've seen my patients develop the consequences of type 2 diabetes, including Alzheimer's disease, stroke, heart attack, visual impairment, kidney problems, and the consequences of the effect of type 2 diabetes on the nerves and the blood vessels in the legs, sometimes requiring amputation. So, for example, just recently I had a gentleman who I've cared for 35 years who's had type 2 diabetes this entire time but has had really good control of his diabetes, and he unfortunately had to have an above-knee amputation. So being able to change someone's diet and completely turn their life around, can completely turn their physical well-being around in 3 months is just unbelievable. And once you've seen it, you can't unsee it. So 18 months ago, I decided that I didn't want to do general practice anymore, and I left general practice to devote the remainder of my working career to assisting people using low carbohydrate and ketogenic nutrition to treat various diseases, including type 2 diabetes. And together with dietitian Nicole Moore and health coach Jodie Bund, we form a partnership with patients who come to see us, and we assist them to achieve their goals, which are often related to improving metabolic health and reversing type 2 diabetes. In the broader context, the longest trial of therapeutic carbohydrate restriction in primary care to treat type 2 diabetes has been undertaken by Dr. David Unwin and his team at the Norwood Surgery in the United Kingdom. Over the last 10 years, the team have been offering every patient with type 2 diabetes the opportunity of trialling a low carbohydrate diet. He has published his 8-year data, and this is given in the reference at the bottom of the slide. However, he's very kindly agreed to share with me his 10-year data. So over 10 years, this approach has been offered to 569 patients with type 2 diabetes, and of those, 47% or 258 have chosen to trial a low carbohydrate diet. And of them, 50% or 130 patients have achieved type 2 diabetes remission, and a remaining 47% have achieved improved control of their type 2 diabetes. So in conclusion, if I had a patient sitting in front of me who had terminal cancer and I was counselling them about treatment options, and I had a treatment up my sleeve which simply required dietary change, and with it that I could achieve a 10-year remission rate of 50% and a 47% chance of improved control of the cancer, but I didn't offer it to them because I thought it was too hard, or I thought that it mightn't work, or I thought that it might stigmatise them. How would that patient perceive me when they found out? In fact, how would their family and the rest of the community and my peers perceive me? And so it should be with type 2 diabetes. It is our professional and ethical responsibility to offer every person suffering with type 2 diabetes the opportunity of improving their diabetic control and, in fact, the opportunity of putting their diabetes in remission by offering them a therapeutic carbohydrate reduction or a low carbohydrate diet.